Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me. Actually, he self-referred. He had a difficult time with his first eye. This patient does have a cataract, probably a challenging case, but the patient ended up having a posterior capsule rupture with this other surgeon done elsewhere, ended up having trouble with the vision and persistent problems, just having pressure issues, inflammation issues. And so finally, the eye got settled. He was really traumatized from his experience over there. And so he came to see me hoping for a better experience. And so I'm going to show you how we tackle this very challenging cataract case. And again, this is just essentially a continuation of how I approach my cataract surgeries. And hopefully, by minimizing ultrasonic energy and vacuum use, I'm able to leverage mechanical fracturing forces to achieve a safe and excellent outcome. So I use a corneal marker, which will help me to center and size the rhexis. And then make a paracentesis incision, first on the right side and then the left side, using the cotton tip to steady the eye. I try to get a nice flat approach parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then when I'm ready, I dive down and enter. I'm recentering the patient here because the patient's already moved, even though we just got started with the case. So anytime you find yourself at the limits of your focus, just go ahead and recenter. And that's the best way to make sure you don't run into trouble. You don't want to have a centering issue when you're going through a really important part of the case. And this is the puncture style rhexis using the Haldi Percar forceps. I punctured the center, pull down, grab the right side of the tear going around circumferentially. I'm using the cannula to hold the eye. This patient, again, had some movement, and this is the right eye. This allows me to really control Bell's reflex. If the patient tries to look upward to the top of their head, I'm able to use the cannula to keep the eye nice and steady. And I'm using the corneal mark that I made as a guide to hopefully achieve a well-centered and sized rhexis. This is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge, contra-incisionally, point the tip down, get a nice wave, decompress on the left side, sweeping underneath the rhexis edge, and then sweeping on the right side as well, hooking the peripheral lens, and the lens begins to spin. You can see this is a really dense cataract. You can see the redness color of the lens, and when I push the cannula into the lens material, you can see how sharp, I don't know how else to describe it, it looks sharp, the lens material on the surface of the lens. So removing the surface epinuclear material, and then I go to bevel up mode, switch to sculpt, and I'm in the dense setting. I'm going to go ahead and sculpt a central trough. Now again, this is not stop and chop in the traditional sense. I'm able to sculpt a central groove, but the difference with stop and chop is you try to crack from the top and you can get a Pac-Man effect, which is completely useless, especially because in these dense cases, that Pac-Man effect, the hinge is that posterior plate. And so you want to get a nice groove, but more importantly, you want to fracture from the equatorial side. So I'm placing the chopper around the rhexis edge contra-incisionally, And I have the instruments deep in the lens material. I'm able to fracture the lens from the equatorial side, and that's called terminal chop. I'm able to propagate that chop and tear all the way through and through. You can see that sudden loss of resistance, and that means I was able to get all the way through. I place a chopper under the right heminucleus, pulling it centrally toward the phaco-tip, fracturing the right heminucleus in half. That is the cross chop. Doing the same maneuver around that first quadrant, crushing the lens completely in half, and then using some vacuum to lift that fragment up, crushing it between the instruments, and then emulsifying the lens piece. So in this case, terminal chop, like all of the super dense cases, you want to debulk the central core because it's so dense. If you don't, you're going to have a higher chance to have that posterior plate effect or that flower petal effect where the central core of the flower is holding all the petals. It's really very inefficient and really doesn't make sense to do cataract surgery this way. By doing it this way, you're able to conquer the posterior plate and go through and through. So place the chopper around that second quadrant, pulling the chopper central toward the phaco-tip, fracturing the lens completely in half. Again, the phaco-tip is acting like a chopping block, and it allows leverage for that chopper to crush the lens piece completely in half. Placing the chopper around that second piece of that second quadrant, hooking the peripheral lens, and then crushing the lens against the phaco-tip, again, like a chopping block. Once the lens piece is smaller, I'm able to get the instruments around the lens piece, crushing it between the instruments, crushing the lens into smaller and smaller pieces, and then fluttering my foot pedal to remove and emulsify the lens pieces. By utilizing and leveraging mechanical fracturing forces, not only are you using less ultrasonic energy, which is better for the cornea, but because of that, you're not being too aggressive and your chance of posterior capsule rupture is much lower. So I turn that second heminucleus in front of me, placing the chopper around the lens, hooking the equator, pulling it centered toward the phaco-tip, fracturing the lens against the phaco-tip, again acting like a chopping block, and I'm able to separate the lens in half, placing the chopper around the third quadrant, pulling it centered toward the phaco-tip in the same maneuver, fracturing the lens completely in half again, using the phaco-tip as a chopping block. Lifting that first piece up with some vacuum and then getting around it with a chopper and then crushing the lens between the instruments. Once the lens pieces are small enough, I'm able to crush the lens into smaller and smaller pieces and then emulsify the lens piece. You can see this is really a dense piece, and the lens pieces are still jigsawed together even though I removed the first heminucleus. But you be very careful and methodical using the instruments to help lift pieces up, using some vacuum as well. And again, you're using the vacuum just to reposition the lens pieces and then utilizing fracturing forces to crush the lens pieces into smaller pieces. And once the lens pieces are small enough, using ultrasonic energy to emulsify the lens pieces. Again, I like to use mechanical fracturing forces, which helps to reduce the use of ultrasonic energy. It allows me to achieve clearer corneas post-op day 1. And again, because you're using less ultrasonic energy in vacuum, guess what? Your chances of buzzing the posterior capsule are less. I mean, it's not rocket science. If you're utilizing it less, your chances of causing harm are less. I mean, it makes more sense. If you're driving all the time, your chances of getting in a car accident are higher versus if you drive less. And so if you're utilizing less ultrasonic energy in vacuum in the context of a very dense lens, then your chances of rupturing the posterior capsule are lower. And oftentimes, because the lens pieces are so stubborn and they don't want to come out, people tend to get frustrated and they go pedal to the metal, and that's when bad things happen. But you can see throughout this case, I am not frustrated. I don't go pedal to the metal. I don't feel like I'm stuck. Because when you get stuck, you get frustrated. And when you get frustrated, you start to go pedal to the metal. Trust me, I've been there. When I was a learning surgeon, that's what you do. You're like, oh, the lens piece is not coming up. Push the pedal farther down. And if you're not careful with your phaco tip position. As the lens piece comes up, again, these are dense pieces. What happens? You clear the piece with high ultrasonic energy and then vacuum, and then you get the post-occlusion surge. And then if you get post-occlusion surge, what follows the lens piece? The posterior capsule. And the posterior capsule then goes into the port, and then you buzz it, and you have a hole. And so that's why using high amounts of ultrasonic energy is so dangerous, because you can get the post-occlusion surge. If you get the post-occlusion surge, then you're going to have the posterior capsule follow the lens piece because you're using high levels of fluidics and ultrasonic energy, and then you're going to rupture the posterior capsule, which is probably what happened to that first surgeon when he had his first eye done and ended up with a problem. But you see here, I'm very controlled throughout all my maneuvers. I am never utilizing ultrasonic energy in an unsafe way. I'm leveraging mechanical fracturing forces throughout the entire case. I am very confident, very controlled, and very safe throughout this entire case. You can see how thick this epinuclear material is. I'm keeping that chopper deep to protect the posterior capsule, and that's the end of the lens removal. So I take the chopper out, push BSS in, take the phaco tip out, and I'll go in with the ironing handpiece. I always start subincisionally, removing the cortical material from anterior to posterior. By doing it this way, you get a cleaner removal of the cortex. I switch to polish mode, polishing underneath the rhexis edge. You always want to check the posterior capsule, make sure there's no fine cortical wisps on the posterior capsule. And again, you won't feel comfortable going port down unless you have a soft tip like this polymer tip and in this low flow polish mode setting. Pulsing BSS into the subincisional capsule fornix, you can see all this lens material being liberated. And that stuff is hiding in the capsule fornix. You can't see the capsule fornix because it's further peripheral. And so another reason why I like to do this maneuver. Able to use the INA handpiece to remove that stuff. Because it's loose, it comes out quite easy. Switch to cortex mode, disengage the fluid, and then filling the bag with cohesive viscoelastic. And this is the sweep. I'm going to sweep underneath the rhexis edge to remove any lens epithelial cells, first on the left side and then the right side. And as you know, with these super dense lenses, there is a higher risk for zonulopathy. So I always put in a 3-piece lens in these cases. And since I have a smaller incision, I have to widen the incision to accommodate the cartridge and the injector. So go ahead and use my diamond blade to widen the incision and go in with the injector, bevel down very carefully here. Oftentimes with that pressure, it causes the OVD to come out because this is a cohesive, and I don't want to make the wound so big that it doesn't cause any resistance to go in. So it's a little bit of a Goldilocks here. You want to have it tight enough, but not too loose, but that causes the viscoelastic to come out. So I go in bevel sideways, making sure that that leading haptic is going into the bag. I want to make sure that the bag is completely filled before that leading haptic comes out. You don't want to cause any stress on the zonules. It's just going to cause stress on you. And it makes no sense. Just fill up the bag completely so there's no traction on the capsular bag zonules, because you can have PC rupture at this stage of the game if you're not careful. So the leading haptic is into the capsular bag. I wanted to push in more viscoelastic to fill the bag. Now I'm using the Maltzman to dial the trailing haptic into the bag. So I go in with irrigation off, activate irrigation, quickly go underneath the lens. What I'm actually doing here is I'm polishing the posterior capsule. There must be some fine cortical wisps in the subincisional area first. Polishing underneath the rhexis edge here. Switching to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who had a complication, a bad experience elsewhere. He came to see me, hopefully with a better experience. He had a really dense cataract. I went ahead and performed terminal chop with multiple executions of cross chop. With cross chop, you're able to use the chopper as the knife and the phaco tip as the chopping block, and you're able to amputate the lens pieces from the rest of the lens, chopping them into smaller bits, starting from the equatorial side, hooking the lens peripherally, and then pulling the chopper towards the center and cutting the lens against the phaco tip. Terminal chop is when you're able to sculpt a central groove, but rather than cracking from the top, which ends up with a Pac-Man effect because of the posterior plate, you go out to the equatorial side, you'll be able to fracture the lens from the equatorial side, which causes fracturing of the lens through and through, and so you won't have a posterior plate effect in this situation. I'm able to leverage mechanical fracturing principles and concepts to use less ultrasonic energy. This allows a better result, less trauma to the corneal endothelium, better vision, faster visual recovery after surgery. And lastly, but not least, is I'm able to have a very controlled execution of lens disassembly without having to use pedal to metal, ultrasonic energy, and vacuum. Because when you do that in this setting, there's no epinucleus to protect you, there's no cortex to protect you, and when you have that post-occlusion surge, you're going to rupture the posterior capsule. So that's most likely what happened to this other surgeon. Again, it happens to a lot of surgeons because I see it all the time. And it happened to me when I was a resident. And then early in my career, when I was dealing with these tough cases, I had this. And so by utilizing mechanical fracturing techniques, double chop, cross chop, terminal chop, my incidence of posterior capsule rupture in these situations has essentially dropped to zero because I do surgery a radically different way from when I used to do it. And to me, the proof is in the pudding because I'm able to execute this case this way in contrast to presumably this other surgeon. Again, those are traditional techniques. There's nothing wrong. I'm sure the person did the best they could. But you have to look at the surgery a little differently, and you want to minimize risk but maximize efficiency. And this is why I feel these techniques are far superior to those that are out there. And I invite you to try these techniques. So this is why I believe these techniques provide a competitive advantage whenever you're encountering the dreaded cataract. So I hope this was helpful to you, and I thank you for your attention.